For this chapter, we're going to focus on taking care of patients and managing patients with disorders of the entire urinary system. Here are the objectives for Chapter 49.
This slide is going to be just a review. Again, remember your parts of the urinary system. Understand that our normal urinary system helps with emptying urine, which helps rid the body of waste products, including acidic products, and has an intact mucosal barrier. So it does help with reduction of bacteria in our body. However, due to that mucosal barrier, we do have a high risk of infection since our urinary system is a sterile system. Remember, normal urine output should be approximately 1,500 mLs per day, so 1,000 to 2,000. Right about that 1,500 is appropriate for a full day. Should be greater than 30 mLs per hour output. And your normal pH level is 4.5 to 8. Okay, so one common disorder that we're going to talk about that you will see a lot in your patients is a urinary tract infection, or UTI. So UTI is an infection caused by different microorganisms, usually a bacterial infection, in the urinary system. This infection can be anywhere along the urinary tract infection, but usually it's classified either by an upper urinary tract infection or a lower urinary tract infection. In our lower UTI, this would be an infection of the bladder, also known as cystitis, the urethra, known as urethritis, or in the upper urinary tract, which is kidneys, called pyelonephritis, which we're going to talk about in a couple slides, or the ureters, called ureteritis. UTIs are common in women because of our shorter urethras, and due to some of the risk factors that we have that we're going to talk about later in this lecture. Normally, our urinary tract has different defense mechanisms or different ways that it helps to prevent infection. So one of the main things is urine flow. So as we urinate, the urine flushes out bacteria. So that helps to clear out our urethral openings from having bacteria that can cause those infections. The acidic level of our pH balance in our urine also helps to inhibit bacterial growth, but when our acidic pH level is not correct levels, then that bacteria can grow as well. Our urea concentration helps to prevent bacterial growth by providing an antimicrobial environment. Our mucosal barriers act as a barrier to prevent infection or bacteria from entering into our urethra. And in men, prostate secretions also have antibacterial properties. So most of these defenses help to prevent that bacterial growth, which can lead to infection, but sometimes different compromised defense mechanisms can lead to that bacterial growth. So our pathophysiology for UTIs, or the reason it occurs, is bacteria, usually from the perineal area or the GI tract, enters into the urethra. And this is most common in females due to inappropriate wiping. So when a female wipes, they should wipe from front to back, so from urethral opening to anus. That way they're not taking that bacteria from the GI tract and the rectum and wiping it up towards the urethral opening. It can also occur due to individuals that are not urinating after intercourse and having that bacteria that's present in those areas go into the urethral opening. Once those bacterial entities or microorganisms enter the urethra, they travel up towards the bladder and can infect the bladder. So it can lead to cystitis or a bladder infection. Our most common pathogen that causes a bacterial infection for a UTI about 75 to 95% of our UTIs is E. coli, and that bacteria is found in the rectum and GI system. So anytime you see a patient that has a UTI and it's tested and comes back positive for E. coli, chances are they have a bacterial UTI from inappropriate wiping or, having the GI tract come into contact with the urethral opening. For our patients, besides women having that short urethra, women are also at higher risk for UTIs due to menopause because of low estrogen levels and a drier lack of mucus production, increased sexual activity, pregnancies, and use of spermicides. So all of these things can lead to a UTI in women. For men, prostate enlargement and anal intercourse can lead to an increased risk of UTIs for male patients. Urinary stasis, use of indwelling catheters, poor hygiene, so not cleaning your urethral openings enough, diabetes, which can lead to a higher sugar content of the urine and lead to bacterial growth, dehydration, immunosuppression, those are causes of our UTIs. So remember, our patients with indwelling catheters, this is the major cause of hospital-acquired UTIs. So we want to make sure that a patient has a decreased use of indwelling catheters or appropriate catheter care. Excuse me, sorry. Appropriate use of catheter care when they have an indwelling catheter. For your clinical manifestation or patient cues, when we have our lower UTI with cystitis or uritis, this is going to be painful urination, so dysuria, urinary frequency and urgency, feeling like you urinate but you just are not emptying that bladder enough. You have to pee every 5 seconds. There's burning when you urinate. You may have a foul smelling urine or cloudy urine. Sometimes, occasionally, there's hematuria, but not too frequently. Usually it's just cloudy and foul smelling. And you may have some suprapubic pain or pressure. So those are the most common causes or most common clinical manifestations of a lower UTI. For our upper UTI, pyelonephritis, we're going to talk more in depth on 2 slides from now, but your pyelonephritis is going to have flank pain and costovertebral angle tenderness or CVA tenderness. That's going to be a pain in the back area where those kidneys are located. Your patients will also report having fever, chills, fatigue, and maybe signs of a systemic infection, especially if that's gone throughout and not been caught right away. For our older adult patients, they will also have some atypical symptoms that are most common in elderly patients with a UTI. This is going to be confusion or delirium, and they may have some new onset incontinence. But for our older patients, a sudden change in mental status is usually the first sign of a UTI. Okay, so check that. For our UTI, our diagnostic findings, we will do a urinalysis or a UA, looking for any pyuria, WBCs in the urine, looking at any leukocytes and possible hematuria. We'll do a culture and sensitivity of that urine, where they look at what bacteria grows to identify what organism is present and be able to pick an antibiotic that's sensitive to that bacteria. Don't forget, get cultures before you give the antibiotic every single time. So you would do a urine and culture and sensitivity, and then start an antibiotic. Usually they start a broad spectrum antibiotic that covers a wide variety of bacteria, and then once that culture and sensitivity comes back, they may change that antibiotic to something a little bit more specific. We'll do a WBC count in labs and look at risk for a systemic infection, might do a sepsis workup, looking at lactic acids and things like that if it goes into the body. We may also do an ultrasound or a CT, which just helps to detect obstructions or stones that could be causing a UTI. For your medical management, for an uncomplicated UTI, usually we'll give antibiotic therapy, something like Keflex or Bactrim. Cephalexin is Keflex, and trimethoprim sulfamexidone is Bactrim. So those are your two meds that we usually give for an uncomplicated UTI. If it is a complicated UTI, meaning it's a longer duration, or the patient's really got a lot of symptoms, they may give ciprofloxacin or Cipro, or levofloxacin or Levaquin. Just make sure to always get the specimen before you give the antibiotics and educate your patient on proper antibiotic use. So completing the full course of antibiotics, even though their symptoms resolve, make sure they take those antibiotics the same time every day. Make sure they take a probiotic with the antibiotics so that they don't get C. diff or something like that from taking antibiotics frequently. And just make sure that you educate them on proper reduction of a UTI in the future. For our prevention and education, what we want to educate our patients, we want to make sure that they wipe front to back, especially in those females, to decrease the risk of bringing any bacteria into the urethra. They should be increasing their fluid intake, especially water and pure cranberry juice. Cranberry can help to acidify that urine and help prevent bacterial adhesion, but we want to make sure that it's pure cranberry juice and not a cranberry juice cocktail, since that has a lot of sugar in it and can actually increase the bacterial count. They want to make sure that they increase their fluid. So about, 2 liters a day, they should increase that water intake to help increase their urine to flush out the bacteria. Always make sure to void every 2 to 3 hours. So holding your urine and not urinating frequently throughout the day actually increases your risk for your UTI, because we're not emptying that bladder and flushing the urethra out. So nurses tend to have a higher risk of UTIs as well. We want to urinate after sexual intercourse. So any bacteria from, different parts of the body don't go into the urethra. So always urinate after. Avoid any tight clothing or nylon underwear. We should always wear cotton underwear. Helps breathing and helps decrease bacterial count. Make sure to avoid bubble baths, any douches, scented soaps, hot tubs, those types of things. If you do those things, just make sure you wash afterwards and urinate frequently. If you're on any antibiotics, you want to make sure to avoid alcohol and finish that full course so that bacterial infection doesn't come back. So our nursing management, just make sure that we focus on treating the symptoms. We can encourage complete emptying of the bladder, teaching them good hygiene, observe urine color, clarity, and output, make sure that the patient understands medication adherence, reinforce preventative habits, increase those fluids, give pain medications as needed, fever reduction if they're sick, and just monitor for signs and symptoms that UTI could be getting worse. Okay, again, our UTI diagnostic and management, so it's usually a urinalysis or a culture and sensitivity that we do to figure out if it is a urinary tract infection, if there's bacteria present. Once we identify that, we'll get the patient on some antibiotics, proper hydration, making sure they flush out that bacterial infection, and educate and maintain good hygiene practices. We should be encouraging about 2 to 3 liters per day, teaching good wiping habits front to back for females, making sure they void after intercourse and avoid baths, douches, and perfumed soaps. Okay, so we're going to talk about pyelonephritis. Pyelonephritis is an infection of the actual kidneys, and this occurs when we don't catch and treat a lower UTI. So that bacterial infection is able to go from the bladder up into the ureters and go into the kidneys themselves. For your patients with acute pyelonephritis, they're going to complain of that fever. They're going to have CVA tenderness, nausea, chills, and flank pain. So that flank pain is something that really ties you in to the fact that those kidneys have the infection in them. So that's back in the back area, kind of in between the ribs and the pelvis, is where you're going to have that pain and tenderness. For our patients with pyelonephritis, this could become systemic. So pyelonephritis can lead to sepsis and can lead to death. So we really want to make sure we identify pyelonephritis and treat it quickly. Our management is going to be IV fluids, so flushing that bacterial infection out of those kidneys down through the urinary tract and out of the body. Give them antibiotics that are sensitive to the bacteria that's present. So making sure we get a culture and sensitivity prior to bacterial start or prior to starting those antibiotics. And then making sure that we give pain medication and lots of rest. We want to make sure that we monitor for sepsis. So we're monitoring for changes in the blood pressure, the heart rate, and the temperature of the patient. And then we want to monitor lab levels for our lactic acid, since lactic acid is an indicator for sepsis. For your patients, we want to make sure that they're not hypotensive and tachycardic. So once the patient starts to become hypotensive and tachycardic, this can be the first indicator signs of some sepsis occurring. Making sure our patients start antibiotics, they finish the whole course of antibiotic therapy, and we see those symptoms changing and getting better. So we should have a decrease in a fever, decrease in WBCs, decrease in that lactic acid, and pain levels going away. So pyelonephritis is a worsening, kind of a severe UTI. So we want to catch that early on these patients. Okay, so we're going to talk about urinary retention. Urinary retention can cause a lot of the disorders that we have in Chapter 49. So it's important to know some of the factors for urinary retention and how we would be able to catch it early and resolve urinary retention. So urinary retention is the inability to completely empty the bladder. Usually this is acute and can be sudden and painful, but it can be chronic and be persistent and something that people have to deal with. So urinary retention is that incomplete emptying of the bladder after urination or the inability to void at all despite a full bladder. So maybe your patient starts peeing, but they can't fully empty the bladder, or they feel like they have to pee and that bladder is full and they can't pee at all. So there's two different kind of ways that you'll see your patient have urinary retention. Okay, sorry, I just got a thing on my phone, some alert thing. Sorry. So for our acute urinary retention, these patients are going to have a sudden, painful inability to urinate, and this can oftentimes be considered an emergency because that distended bladder can continue to fill up and can actually burst. And so we want to make sure that we take care of that right away. With chronic retention, these patients usually will void, but it'll be small amounts frequently and can lead to that inability to empty the bladder completely. We see this a lot with patients who have overflow incontinence and post-void residual on bladder scanning. So when the patient pees, we'll do a bladder scan and we see that they still retain a lot of urine in the bladder. So for our normal urination, this is controlled by our bladder and our urethral sphincters and nervous system signals. So normally when our bladder volume reaches about 250 to 400 mLs, our receptors in our bladder that stretch signal the brain saying, okay, I'm stretched too far, I've got too much urine in my bladder, I need to pee. And so then the brain sends that signal and says, oh, I have the urge to void. Those muscles in the sphincter, the urethral sphincter, relax and allow the urine to be expelled. In retention, however, this coordination fails and the bladder cannot contract properly, or it's due to an outlet obstruction. So you either have a problem with the bladder constricting and urinating or a problem with the urethral opening itself in which it's obstructed, and so that urine can't come out. So for our urinary retention, we have a mechanical obstructive problem which would be a cause of the bladder being obstructed. That would be through things like BPH, which is most of the reason in men, a urethral stricture or stones, or a tumor or some sort of pelvic mass. You can also have post-surgical swelling, especially if there's been any urological surgeries or anything like that, that can cause a blockage of the urethral opening. For our urinary retention that is a functional or neurogenic problem, this would be due to things like a spinal cord injury or musculoskeletal problems like MS, diabetic neuropathy, or medications. A lot of medications like anticholinergics or antihistamines, opioids or anesthesia can cause a neurogenic or a loss of function with the bladder. For our patients who have had surgery or any surgical procedure where anesthesia is used, anesthesia can actually reduce the detrusor muscle activity in the bladder, so that bladder becomes kind of sluggish and sleepy. For our psychologic causes, so sometimes patients can have anxiety or an inability to relax pelvic muscles, and so that can also cause a neurogenic or a sleepy bladder. When our patients cannot have, or when our urine, when urine and our bladder doesn't work, urine can't exit the bladder, and so that bladder starts to build up urine due to build up pressure due to that increase of urine in the bladder. So that bladder starts to distend, good grief. The bladder starts to distend and grow and get bigger and bigger and bigger. And so when that happens, those muscle fibers and those the stretch sensors inside of our bladder start to weaken. And so that residual urine that accumulates in that bladder, or that stagnant urine, starts to build up bacteria and can lead to a UTI, which we talked about in the previous slide. Urine can then back up into the kidneys and can lead to pyelonephritis, which is an infection of the kidneys. It can also back up and lead to hydronephrosis, which is an enlargement of the kidneys and a buildup of urine into those kidneys. It can also lead to bladder wall hypertrophy, which can lead to that bladder wall becoming kind of thinner and weak. If we do not take care of bladder distension and a buildup of that urinary retention, then pressure can build up in those kidneys and can lead to renal damage or kidney failure due to an intrarenal cause. So if you remember back to our AKI discussion, then that could cause renal damage, intrarenal damage, because it's damaging the cells of the kidneys itself. For your clinical manifestations, so for our patients with urinary retention, they're going to have either an inability to urinate at all, or they're going to have urination, but they're going to feel like they're not emptying their bladder completely. They might have some hesitancy or weak or intermittent streaming, so maybe they urinate, then they have to stop, then they urinate, then they stop, or the urine just dribbles out. They can have a feeling of fullness or persistence after voiding, so like they void but they still feel like their bladder is full. They're not able to void enough. They could have painful urination. They might have frequent small voiding, so they're urinating every 5 seconds and it's just like a little bit, a small amount. Or they can have signs and symptoms of infection as well, so things like cloudy urine or painful urination or that suprapubic tenderness. So some of the assessment findings we have is our palpation. So we would obviously palpate above the symphysis pubis, feeling and palpating for a distended bladder, feeling and palpating for pain. We would do a bladder scanner. So this is an ultrasound type of a scan. It's non-invasive. It doesn't hurt. We can do it on anybody, and usually a UAP or a CNA can do this even. So it's, not high risk or anything, but this measures how much urine is in the bladder. We can either do it as a post-void residual, which is a PVR. This is after the patient urinates, see how much is left in there. Greater than 100 after voiding indicates incomplete emptying, and more than 300 mLs usually indicates some pretty significant retention. We also can just do a random bladder scanner where if our patient's kind of complaining that they haven't urinated or we've noticed that they haven't urinated, we can do a bladder scan as well and just see how much they're retaining. For our patients, we'll also do a urinalysis or a culture and sensitivity just to make sure there's no urinary tract infection that could be causing the retention, and could do a renal ultrasound or a CT to look for any hydronephrosis or renal obstruction or kidney obstruction itself. But our bladder scanner is the safest non-invasive assessment tool that we have, so we'll usually do a bladder scanner. Don't forget your complications of urinary retention. So this is going to be your UTI, bladder distension, hydronephrosis, renal failure if we don't catch it early. So making sure that we really relieve the urinary retention. So our medical management or nursing management for this immediate treatment is going to be to scan the bladder, see if there's enough urine in there. And if they're retaining enough urine in the bladder, then we would do catheterization. Now, most places with some acute urinary retention, we do a straight catheter, and you'll do that about 3 times. If that persistent urinary retention keeps happening, then that patient usually will then get an indwelling catheter. So we do the intermittent catheterization or straight caths more until we prove that it is in fact a problem that's going to be ongoing, and then they would get an indwelling catheter. If there is an obstruction or a problem with that urethral opening, then the patient could get a suprapubic catheter as well. So we'll talk a little bit about the different catheter types, and we're going to talk about some assessment and things that we need to do with catheters, since anytime we do something, it puts them at risk for something else. So if we put a catheter in our patient, it puts them at risk for other things. So we'll talk about that. We also want to look at the underlying cause. So if it is a problem with the prostate, like BPH, then we may give some medications for that, like tamsulosin or finasteride. Those 2 medications will help with BPH enlargement. Or we can do a surgical procedure known as a TURP. This can help resect a little bit of the bulk of that prostate tissue. We can give antibiotics if it's an infection reason, if it's a neurological cause due to that bladder being a little bit sluggish. We can do intermittent self-catheterizations or straight caths. We can do a bladder training where you have the patient sit down on the toilet every hour and bear down to try to get that bladder emptied. Or they can take cholinergic medications like Bethanol. If it's a post-operative reason, we want to make sure that we do the early ambulation, give the patient privacy, maybe try running some water to stimulate voiding, or look at doing intermittent straight catheters as well. Making sure that we educate our patients on voiding at regular intervals, usually about every 2 to 3 hours. After urinating, they can wait 2 to 3 minutes and then try again. That just helps them with double voiding to ensure that they empty their full bladder. Avoiding excess alcohol and caffeine, as this can worsen retention. Have them make sure to review medications that could cause urinary retention, things like decongestants and antihistamines, so Benadryl or Sudafeds and things like that. Make sure to increase their fluid intake unless it's contraindicated, but making sure they're taking enough urine to flush out their bladder and their kidneys, and making sure that they know when to call the doctor or seek care if they're not urinating appropriately. Okay, so on the opposite side of urinary retention, we have urinary incontinence. So urinary incontinence is the involuntary loss of urine which usually can cause some hygienic problems or social causes. So, embarrassment, where somebody urinates on themselves or accidentally pees themselves. This is not always a normal consequence of aging, but aging does increase risks for it. So not everybody pees themselves when they're older, but older people do have a higher risk of this because usually their urethral sphincter gets a little bit weaker, or there's different neuromuscular problems with the control of urination. So if you remember, the bladder stores the urine until those stretch receptors are activated. Then the brain and spinal cord signal the sphincter to relax and urine exits. Um, Usually this control depends on a nervous system that's functioning correctly, pelvic floor muscles that are strong and functioning correctly, and strong urethral sphincter tone. So any problems in any of these will lead to some urinary incontinence. Now there's a couple different types of urinary incontinence. There is stress incontinence. So this is leakage that occurs with increased abdominal pressure. So oftentimes we see this with women who have a weak pelvic muscle, especially after childbirth. So these are the people who will pee themselves when they cough, they sneeze, they laugh, or they exercise. So anything that puts some stress or pressure on their abdomen area and that bladder and causes urinary incontinence to occur. Then we have urge incontinence. So this happens when there is a sudden intense urge and an involuntary loss of control. So oftentimes this is from overactive bladder or a neurological disorder like stroke or MS. So these are the people who will come in and they say that they can't get to the bathroom in time, that they just feel like they hurry to the bathroom, but they end up wetting themselves. For our overflow incontinence patients, this is where the bladder overfills and there's a constant dribbling that occurs. Oftentimes we see these in patients with a BPH obstruction or on medications that can cause overfilling of the bladder. So these patients oftentimes will have a weak stream or they will have dribbling after urinating, so post-void dribbling. They will also have a high residual on that post-void bladder scan. For our patients with functional incontinence, this is somebody who might have physical or cognitive barriers that prevent timely toileting. So patients with dementia or immobility factors, that's where they have normal bladder function, but they can't get to the toilet in time. Then we have reflex incontinence. This is patients that have involuntary urination without any urge or awareness occurring. Oftentimes we'll see this in patients with spinal cord injury or problems with their central nervous system. They will be voiding at predictable intervals, but they won't have the feeling that they need to urinate. So they're the ones that might wet the bed every 3 to 4 hours, but they don't even know that they're going. Then you might have mixed incontinence. So this is a combination of stress and urgency incontinence. These patients are usually older patients or have a weak pelvic floor. So these patients usually will have some leakage with exertion. So they will urinate as they're coughing, and then all of a sudden they have to go pee. So for your patients, your clinical manifestations or their cues with urinary incontinence, you will often see that they have leakage of urine, either intermittent or continuous. They might have some urgency, frequency, or nocturia. They might have post-void dribbling or that incomplete emptying of their bladder. They might have some social withdrawal or embarrassment. Obviously, if they're having urination problems, they might be a little bit embarrassed, or they might have skin irritation or breakdown, especially from that repeated moisture exposure. For our patients to diagnose this, usually we'll get a good history, we'll get a good observation of their voiding habits, looking at any leaks or triggers or problems with their urinary retention or bladder problems. We would want to rule out a urinary tract infection, so we would do a urinalysis and a culture, and then we might look at a pelvic exam or looking for any prostate, BPH enlargement, or loss of sphincter tone. For our patients with urinary incontinence, these patients can have skin breakdown, so we want to monitor for any moisture-associated dermatitis. We want to monitor them for falls, especially if they have any stress incontinence or anything where they're hurrying up and running to the bathroom, they might fall. Looking for any social isolation or depression. For our management, oftentimes we first will do behavioral interventions. So those would be things like pelvic floor exercises, also known as Kegel exercises, which help to strengthen the sphincter and pelvic muscles. We would do bladder training, having the patient void every 2 to 3 hours, gradually increasing that interval to help strengthen their bladder control. We would want to do voiding at certain times for patients that have any functional incontinence, and then limiting caffeine, alcohol, while also encouraging adequate hydration. So just, monitoring their fluid intake and making sure they're going to the restroom at timely intervals. For our patients with that stress incontinence, we would want to decrease any abdominal pressure. So we could look at things like weight loss and abdominal muscle strengthening. For our medications for stress incontinence or different types of incontinence would be anticholinergics. This helps to decrease bladder contractions and helps with urge incontinence. So that would be medications like oxybutynin or tolterodine, which is ditropan and detrol. You could give beta-3 agonists like mirbetriq. This helps to increase bladder capacity and helps to relax those detrusor muscles. We could do an alpha adrenergic agonist. Good grief. Alpha adrenergic agonist. Okay, so medications like midodrine. This helps to increase urethral sphincter tone and helps with that stress incontinence. If we have patients that have incontinence related to any weak bladder, we could do a cholinergic agonist like Bethanchol. For our patients that have any type of incontinence that's not fixed with behavioral management or medication management, they can do surgical procedures. So some patients can have an artificial urinary sphincter. This is mostly placed in men after prostate surgery, but if it's a problem with that urinary sphincter, they can have an artificial urinary sphincter. We can also do a sling or a suspension procedure. This can help to lift and support the bladder neck, which can help with stress incontinence. So you might see somebody that has a urethral bladder sling. For your patients, just make sure to maintain healthy fluid intake, voiding regularly, do daily pelvic floor exercises, avoid bladder irritants like caffeine, alcohol, or carbonated drinks. They can wear absorbent pads if needed, but making sure that they report any worsening symptoms, burning, foul odors, or any smells, which can be a sign of infection. Okay, so now we're going to talk about kidney stones or urolithiasis. These are also called urinary calculi, but you'll most commonly hear about them or hear them called kidney stones. So urolithiasis is the formation of stones, which are calculi, anywhere in the urinary tract. They can be found in the kidneys, the ureter, the bladder, or the urethral opening. For our stones, these occur when substances that are usually dissolved in urine, things like uric acid, calcium, oxalate, or phosphate, start to concentrate and crystallize, and they form these jagged little, sharp, tiny little rocks. These can start to obstruct or cause issues within that urinary tract system. And so what we'll see in our patients, our clinical manifestations, will depend on the location, the size of the stone, and how obstructed they cause the patient. But for the most part, there's going to be a couple clinical manifestation cues that you'll see pretty common or frequently. So if they are found in the kidney, they are called nephrolithiasis or kidney stones. These patients will have flank pain and most oftentimes bloody urine, so hematuria. And that's because that jagged little stone is in the kidney, scraping on the kidney tissue and causing bleeding. If they are in the ureter or their uretolithasis, these patients will oftentimes have flank pain that radiates into the groin area. They also will have nausea, vomiting, urinary frequency, urgency, and probably some diaphoresis. With our patients that have stones in the bladder, they're probably going to have some suprapubic pain. They might have urinary retention, especially if it blocks the opening of the bladder, and they might have some signs and symptoms of a bladder infection. In general, most of our patients will have some sort of hematuria, so watch for bleeding in the urine, and they're gonna have quite a bit of pain. So our classic presentation is sudden, excruciating pain, usually in the flank area, oftentimes radiates to that groin area. They're gonna be restless and have hematuria. For our patients, we want to make sure that we catch it early so that they don't have any risk for renal damage or kidney failure, especially due to that prolonged obstruction. Making sure that we don't risk infection, so pyelonephritis or urosepsis. Making sure that we don't cause any hydronephrosis due to that urine backup. For our diagnostic findings, oftentimes they will do a CT scan, non-contrast, an ultrasound, or a kidney urinary bladder, so KUB x-ray. But our CT scan is kind of our gold standard. They usually will be able to identify the buildup of those stones and kind of see where they're at and what they look like. For our patients, our main priority is going to be pain management. Renal pain due to that renal colic is pretty severe. So most of our patients get some pretty heavy opioids or NSAIDs like morphine, Dilaudid, or Toradol, and they might get some antispasmodics, things like tamsulosin or oxybutynin to help relax the ureter. If your patient can tolerate movement, encourage movement, or we might do some heat therapy to the flank area. Moist heat is always beneficial to help move those stones. For our patients, we want to also make sure that they are encouraging 2 to 3 liters of fluid per day to help flush those stones out. We want to strain all the urine, so we'll have kind of a mesh strainer that helps to catch the stones so that we can make sure that we're passing them correctly and we're analyzing them. So strain all the urine, and then we would modify the diet based on the stone type. So if your patient has a uric acid stone or a stone from excessive uric acid, we would want to give a low purine diet, which would be decreasing shellfish and organ meats. If it's due to an increase in calcium oxalate, we want to avoid those types of foods like spinach, nuts, tea, and chocolate. If it's due to a buildup of cysteine, we would want to increase fluids and make sure that their urine is appropriate pH balance. For our patients, usually they can pass those stones as they urinate, and we'll strain our urine and catch those stones. But if they're unable to pass the stones, or if they're too large or are causing some severe obstruction, then they can have a procedure to either remove it or break the stone up. So usually what they'll do is called lithotripsy. This is ultrasonic waves that they put on the patient's urinary tract, and it helps to break up the stone into smaller fragments so that they're passed easily. They can do a uretoscopy, so this is an endoscopic removal where they go into the urethra and they can remove the stones that way. or they can do a percutaneous nephrolithotomy. So this is where they go in directly into the kidneys via small flank incision, but this increases risk for bleeding. They can do open surgery, but this is pretty rare and it's used for large or complex stones. For the most part, they do lithotripsy and break up those stones into smaller, easily passable pieces. So always watch for infection, administer antibiotic if needed, monitor for fever, chills, changes in urinary output. But for the most part, they want to hydrate, increase their water intake about 2 to 3 liters per day. Limit foods that can cause those kidney stones to build up, and then have the patient report any signs and symptoms of infection or obstruction. Okay, we're going to briefly talk about bladder cancer. So bladder cancer is a malignant tumor that originates from either the urinary bladder epithelium or the transitional urothelial cells that line the bladder. It's most common or most frequently found in men and older adults. For our risk factors, cigarette smoking is the most significant risk that accounts for about 50% of those cases, but it also can be due to environmental or occupational exposure, things like different paints or dyes or chemicals, or can be due to recurrent UTIs or long-term indwelling catheter use. Some early signs of bladder cancer would be painless hematuria. So patients may have bright red or rusty colored urine that they notice. They may have dysuria or frequency with urination, a lot of the same similarities to a urinary tract infection. So patients with recurrent UTIs and painless hematuria should always be evaluated for bladder cancer. For our patients with bladder cancer, usually they will be diagnosed with urinalysis or a cystoscopy. Usually this is done with a biopsy for tissue confirmation of cancerous cells. For our patients with bladder cancers, they may have different surgical treatments like a resection or removal of the tumors, or they may have a full radical cystectomy where they remove the entire bladder. This usually will require urinary diversion, and we'll talk about those different types of urinary diversions a little bit later, but these things would be like um, like a ileal conduit or a stomal outpouching to where they would have that stoma that would allow them to bypass that bladder. And again, for the stoma, making sure that it's pink, it's moist, they have adequate urine output, and you're teaching them care for that. They may also have chemotherapy or radiation, and we talked about that in our cancer lecture. So just making sure that we look at chemotherapy, neutropenic precautions, chemotherapy precautions, making sure that any radiation therapy, we're doing things for the skin and things like that. Same thing with surgical procedures, pre-op, and post-op and intra-op, making sure that we, get consent, educate, all of the things that we talked about in that lecture. For your patients' education, we want to make sure that they increase their fluids 2 to 3 liters per day. Same as most of our urinary problems, they should still be drinking enough fluid. Stopping smoking, especially if that is a big risk factor for their cancer. Recognize early signs of cancer reoccurrence, so that hematuria, urinary frequency, and urgency. Watch for complications, especially hemorrhaging, bleeding, any urinary obstruction, any infection or peritonitis or anything like that. So that's just basically a brief overview for you for bladder cancer. Okay, so we're going to talk about 2 different urinary diversions that they might use if the patient has bladder cancer or any problems with that urinary system. We're going to talk about a nephrostomy and a urostomy. So a nephrostomy is where the normal urinary flow from the kidneys to the bladder is blocked or disrupted, and we may need to create an artificial exit in the body to allow that urine to get out. So for our nephrostomy, this is where the drainage is changed directly from the kidney. So there'll be that artificial opening from the kidney directly out of the body. So for this, oftentimes this is due to patients that might have urinary obstruction, a relief of hydronephrosis, or maybe to bypass that kidney completely. For this procedure, a tube is inserted through the skin into the kidney, and that urine will be drained directly into a collection bag. This could be a temporary nephrostomy, or it can be long-term, depending on the cause. But what we want to do for our patients with a nephrostomy is we want to focus on making sure that it's draining correctly, so making sure the tube is patent, monitor that output, make sure that we monitor the draining, making sure that it's more than 30 mLs per hour, monitoring for any signs of infection, making sure to keep the site dry and clean, making sure that there's no pain, which could indicate an obstruction, and we want to make sure that we monitor the site of the nephrostomy as well. We do not irrigate this tube unless it's specifically ordered, and we don't clamp the tube without orders, because this can cause a backup of the urine output to go into that kidney and can cause damage or infection. So for our patients with a nephrostomy tube, we want to make sure to keep the bag below the kidney level, maintain adequate fluid intake, about 2 to 3 liters per day. Report any signs and symptoms of infection like fever, chills, flank pain, or decreased drainage. Avoid twisting or pulling or clamping that tube, and make sure that we empty the bag when it's about halfway full. This will help to keep that nephrostomy working correctly. Now, when we look at a urostomy, a urostomy is a surgical diversion of urine from the bladder out to a new exit site. This is created via stoma, so that red beefy stoma on the outside of the abdomen. This one is usually performed after a cystectomy or a bladder removal due to cancer, trauma, or different chronic diseases as well. For our urostomies, what we want to make sure for our nursing care is to make sure to assess that stoma. So again, it should be red, pink, and moist. Any pale, dusky, or purple coloring of it might indicate that there's not a good blood flow. We want to make sure to monitor output, so making sure that it should be yellow, a nice clear yellow urine output. Monitor skin, making sure that that pouch fits correctly over that stoma, and we're not getting any urinary urine on the outside of the skin that could lead to irritation. Always monitor infection. Make sure to empty the bag before it's full, so that urine's not sitting there getting bacteria in it. Making sure that we clean the system and keep it clean and dry. And then encourage 2 to 3 liters of fluid per day to help decrease risk for infections as well. Our patient should change that appliance every week or so, especially if it's getting kind of gross and dirty, to decrease infection. Making sure to avoid heavy lifting 6 to 8 weeks after surgery to let that site fully heal. Okay, and so throughout the lectures, we've talked a lot about different diagnostic tools and testing for urinary disorders. We talked about a cystoscopy, which is direct visualization with an endoscopy of that ureters and the bladder and urethral opening. We've talked about a urinalysis and culture and sensitivity, CT scans, bladder scans. So we kind of talked about a lot of those. So just go back and revisit any of these diagnostic tools that help to look for different disorders of the urinary system. Okay, so we talked about urinary catheters and kind of how we utilize them for different disorders of the urinary tract. but I wanted to focus a little bit on the different types of catheters, when we use the catheters, and some of our patient education. So urinary catheters are a big risk factor for infection, so we want to make sure to educate our patient on proper use of them. So our different types of catheter are over on the right-hand side. At the top, there is what's called a Foley catheter, or an indwelling urinary catheter. These are the ones that you've practiced with in simulation, and you've probably put some in clinicals. These are the ones that have a little balloon at the end, and they are meant to stay in for longer periods of time. Then on the next one down is our straight catheter, or intermittent bladder catheterization. This is used only one time. It does not have a balloon at the end. You place the catheter in using strict sterile technique as you would an indwelling catheter, but you drain the urine and then remove it. Proper straight catheterizations have a lower risk of infection than an indwelling catheter, so that's why they're preferred for urinary removal of urine in the bladder. As long as you're doing it with sterile technique, they have less of a risk for infection. Those indwelling catheters, the reason why they have high risks of infection is because that catheter is going directly into the bladder, which is a sterile area, and that tube can actually cause bacteria to go up into that tube. Hang on, give me 1 second. I'll be out in just a second. And then we have our suprapubic catheter. So this is the same thing. This is where that catheter is actually surgically placed through the peritoneum into the abdomen. Oftentimes it has a balloon on the end of it, so it's a long term. Then we have a three-way catheter. This is used for continuous bladder irrigation for patients with significant bleeding or clotting. Urine can exit through one port, and fluid can be put in that other port to help irrigate the bladder. A Coude catheter in the bottom right has a little crick at the end of it that helps go past an enlarged prostate, and so those are for patients with some BPH issues. Now for your urinary catheters, the mnemonic to remember for patients that are appropriate to have urinary catheters is Houdini. So patients with any gross hematuria that would need a CBI, or continuous bladder irrigation, they would get a catheter. Anybody with obstruction that's having urinary retention, anybody with urological surgeries where they would need that catheter for short-term period use, anybody with a stage 3 or 4 non-healing ulcer would get that, so that the urine's not causing further skin breakdown. Anybody with strict INOs, so that's your patients in ICU where we're monitoring intake and output every hour, or nursing end of life. So these are patients who are on hospice who want this as a comfort measure. And then patients who have immobility. These are our paralyzed patients who cannot get up, they cannot turn, they cannot move, they can't use a bedside commode or a bedpan. So nursing ease is never a reason for a urinary catheter. Patient request or family request, just because they request one does not mean they get a urinary catheter. This is because urinary catheters have such a high risk for infection. We want to decrease that risk. And here is just a reminder of our patient education highlights. So just ways to prevent any problems with the urinary tract and our kidneys from, getting infection or problems.
And I have added a couple NCLEX questions for your review of this chapter.